Hi, everybody. My name is Christopher Klifto. Welcome to Joint Ventures, a sports medicine podcast by Smith+Nephew. I'll be your host today. I am joined by Dr. Laith Jazrawi and Dr. Scott Trenhaile. This episode will focus on the conundrum that is partial thickness rotator cuff tears and the patient selection regime of biomechanical and biologic solutions. So, Jazz, what percentage of your patients come into your clinic who have shoulder pathology and they have partial thickness cuff tears?
First of all, conundrum, very impressive word.
I sounded it out.
I love it.
Syllables.
And look, it's a good word. It's a good word for this problem. There are a lot more of these patients that come into our office that don't require surgery. And I think that's the key to understand. A lot of these patients, partial thickness tear on MRI, cortisone injection, physical therapy. Okay?
Do you believe in cortisone?
For
you do it?
Partial thickness tears?
40-year-old with a partial thickness.
Depends on the type of partial thickness, right? When we say partial thickness, is it a bursal-sided tear? Is it a bursal-sided tear that's 70%? Or is it just an increased signal in the cuff that they're calling partial? I think the definition and what we're calling a partial tear is very important, and I'm sure Scott will agree with this because it's really going to dictate our management. You get a partial tear in a young patient, traumatic maybe, that's hanging on by a thread, that's a lot different. I'm not going to do cortisone and physical therapy. But if I get a 70-year-old female, comes in, insidious onset shoulder pain, has an MRI that shows some increased signal in the cuff, they're calling it partial thickness, I'm not going right to some sort of bioinductive implant or some sort of surgery, repair. I'm starting with our traditional treatment, physical therapy and a subacromial injection.
Interesting. Scott, what about you?
I think very similar kind of evaluation. The patient's age, the patient's tendon, they all come in with MRIs anymore from somewhere. They get an MRI from who knows where. Historically, these patients would come in with some tendonitis, bursitis, call it impingement, call it whatever you want, but we would treat them with therapy, nonsteroidals, plus or minus an injection, and then eventually get the MRI and then go. And by then it was surgery time. Now everyone comes in with an MRI, so we're kind of forced to think about those things like up front, which is nice because we have the information, but it creates a conundrum of sorts sometimes. So,
yeah, I would add to that. I mean, certainly in Manhattan, a lot of these patients, they have a week's worth of pain, they come in and we offer them, okay, maybe this could be an injection and physical therapy. They want an MRI. And I think we're getting the MRI, just like Scott said, right away. And that's different than we used to do in the past, where they've failed all the treatments and we had a partial thickness tear and we've already done everything to manage them conservatively. Maybe not PRP back then, but that's a whole other discussion. But the idea is that, there is a role for conservative treatment in these patients, depending on their profile.
Well, let's talk about that. Is there a percentage of torn rotator cuff where you say, hey, I'm not going to try at least 6 weeks of physical therapy? You go straight to a surgery. Does everyone get PT? What about for you, Jazz?
Yeah, so I think that, again, it depends on the history. A patient comes in traumatically with a partial tear, and to me, that's a lot different. That can be 40% in a young patient, 30%, numbers that were typically lower than we would traditionally think for surgery. That 50, 60% magic number that came out, which shows progression. Yeah, it's a little different in that type of population where they fall traumatically and they have that. I'm more aggressive doing surgery. Your next question is, okay, they come in with this insidious pain. They have, let's say, I'll make it 49%, and when do you pull the trigger? And to me, that has a lot to do with their activity level, their age, what they've done up to that point. And on those patients, the only difference is I'm probably refraining from an injection because we know some of the negative stuff that cortisone can do, especially to a cuff that we're planning on repairing or doing something with. So I'll send them to therapy sometimes if it's, and that magical number of 50%, I don't know if it's even viable today, but the idea is I'll try some sort of conservative therapy. The other thing is most times they're sent to me, and I'm sure to Scott as well, they've already tried all these things. And you've got them and you're like, okay, well, now's the time for surgical discussion. And I think what's important with these partial tears is before it was always, we have to potentially take this down, and we'll get into this, cut it, put an anchor in. We know some of these don't like to heal. And that would be a painful process to me, to the point that I would do more conservative therapy sometimes and hope that they didn't show back in the office, because I didn't want to cut that, a cuff down. I didn't want to do, and we'll get into it, a partial repair, a pasta repair, which I thought was not only painful, but didn't really make any sense to me, where we were attaching abnormal cuff back down to the footprint. But when this bioinductive implant, the REGENETEN, came out, for me, it was a game changer.
Well, we'll get into that for sure. Scott.
I just want to add that I think another key factor to this is the host. So, what kind of patient is this in terms of comorbidities and other issues, which could sway me one way or the other versus, smoker, diabetic, those kind of problems. Maybe it's a work comp situation on top of that, which could complicate things a bit. And the other thing is this a focal partial thickness cuff tear, chronic or acute, or is this the Swiss cheese partial cuff tear that's just, if you were to go in and take that cuff down, you suddenly realize, where do you stop? Because it's just poor tissue, and those are scary. Those sometimes can get scary. So you conservatively take those down, and when you start to repair those with an anchor, you can run into issues like, wow, that tissue is not going to help with the healing process. So we take it from there in terms of the partial thickness. What kind of tear is it? What kind of host is it? What comorbidities are involved with it?
Yeah, we were all there. Small tear, you go in. Partial, you start to take it down, like Scott was saying, and all of a sudden, you're dictating in your op report, massive repair, double row repair,
convergence, margin convergence.
3 tendon tear.
Right. Yeah. All of a sudden on something that you thought was going to be simpler. And Scott touched on a good point. Some of these tears, they not only in the footprint, these partial tears, they extend into the substance, almost to the musculotendinous junction sometimes.
Yeah.
And those are challenging in these partial tears. And Scott hit it on the nose, the host. Why are these patients getting this, sort of weird tear pattern? Is there something about them metabolically, that their healing ability? So it makes me even more nervous attacking these patients. And pasta repairs, the way we used to do them, it's almost, looking back, it almost seems insane that we were doing some of those type of repairs on these patients.
I think too, the MRI, we're better at reading MRIs now. We are. The radiology techniques are better. The radiologists are better. We're better.
Scanners are better.
Everything's better. So we can look at we can assess tendinosis and partial thickness tearing and the extent by which that is, and really get a sense of how this is going to go intraoperatively if and when we get to that point.
So Jazz, you're in Manhattan, and patient comes in, drops a whole pile of cash. Being facetious, I was a resident. I know that doesn't happen, but they say, "Hey, I want PRP and BMAC for partial thickness rotator cuff tears." What are your thoughts on not the cash portion of it, but just the therapy?
So Chris, that happens a lot in the system, in our office. The patients are getting smarter now. They're sending a message through. We have an electronic medical system where they can send us a note even before they come in as a new patient, because they're within our system. And they ask, they go, "I want BMAC. Will you do it?"
And your answer is?
And the answer is, I haven't even evaluated them, looked at everything. So, I review their charts, and I always go, "Well, you're 85 years old. You're not getting BMAC from me, because I know that your bone marrow is not going to have enough cells to help heal it." But it is a discussion in certain patients. There's a lot of things we don't understand about the utilization of these biologics. And I think from a patient who comes in, and after a thoughtful discussion with them about pros, cons, and the biggest con being you may be throwing your money down the drain because we don't know. As long as they understand all of that, I'm comfortable going ahead with a lot of the stuff that they may want, unless it's someone who's much older who doesn't have the cells, because I will do bone marrow. But short of that, I'm comfortable with the complication profile, that I will do it. And surprisingly, these patients come in, they haven't had any conservative treatment the way we understand it. They've never had a cortisone. They've never done physical therapy. They get their BMAC injection or their PRP. Hey, you know what? You should go to physical therapy. You should start conservative care. And miraculously, they're better, because conservative treatment, including therapy alone, can work. And we know on some full thickness tears as well, in the older population who are okay with some limitations, that it can help with pain and they can end up not needing surgery.
Yeah. What about you, Scott?
As the whole biologic world continues to explode, I think there was some pushback from the academy that said, hey, you guys are stewards to doing the right thing by your patients. There's harmful things out there, and there's a lot of things we do know and a lot of things we don't know about scientifically. And I actually, when those patients are really into that, I refer them to somebody who's really read on those alternative treatment measures. Because when the day is over, we're all surgeons here, right? Like, we do surgery, and we're not one-trick ponies, but we have to know when to operate, when not to operate. And if you start to get into, mesenchymal stem cells and things that that's not really our...
Leukocyte rich, leukocyte poor, like
exactly.
Which PRP, right?
So I try to get those patients to somebody who's really set on that, to say, look, we want to do right by you, and we're going to get you to somebody who treats a lot of patients in this world and knows the data and can do ethically what's right for you. The things surgically that we do, which we're going to talk about in a little bit.
At some point, maybe.
At some point. I know about that. And so I know the data on that. I've been there the whole way. So when we get there, we can discuss it further.
Well, let's go there now. Listen, you guys both have been doing it forever. I'd just love to hear your perspectives from how you both started treating partial rotator cuffs to where you are now in your 15-year careers. Jazz, you want to go first?
Yeah. Thank you. Yeah. More like 20.
10-year careers.
23.
It's 20. I think we're close because we're the same age. So it's been about 23, 24.
Yeah.
That's a great question, Chris, about how the evolution of management of partial thickness tears. And for me, it's gone through these waves, right? So what are the waves? The first wave was the baseball player with a partial thickness tear. And I think back in the 2000, doing my fellowship, we saw a lot of these baseball players, throwers with partial thickness tears. We were doing pasta repairs and sometimes doing a thermal shrinkage, right? To deal with some of the instability. We weren't certainly doing biceps tenodesis at the time. We were doing slap repairs on a lot of these athletes. And looking back, and I can confidently say now that almost everything that I've just described in that patient is probably wrong. Yeah. We probably shouldn't have been fixing their cuffs to tighten them up, because we know in baseball players that to get that rotation, that they need to have that sort of delamination cup tear. Slap tears. We know that even with some of the newer techniques, there is a failure rate, and the older these patients get, you may want to consider an alternative procedure, especially if they're above 30. Not many athletes above 30, but there are. We're seeing them in tennis players, even baseball players. There's leagues all over New York City.
Yep.
And then thermal shrinkage, right? That has gone by the wayside. So this idea of, okay, well, we don't all take care of baseball players. Who else do we take care of? Okay, what about partial tears in the weekend warrior? We started to fix those too. Well, we ended up getting a lot of stiffness issues in those patients. And that was a challenge as well, from what I brought up about repairing abnormal tissue back to the footprint, or in essence, tenodesing part of the cup that didn't belong in that area. And eventually you got a follow-up MRI. They were better, some other reason, the repair didn't work.
So you're doing in situ, it sounds like.
In situ, yeah. And then the ones that I took down that were partial, they were typically, at the time before this bioinductive implant, the REGENETEN implant, if it was 70%, I was starting to take it down. Just because I knew I could do, I could do a better job, right? I could do a better job taking it down. Now, a lot of my thoughts have changed. You know, the introduction of the REGENETEN bioinductive implant, it has made things a lot different. In the past, we would take this tear down, complete it, repair it. Oftentimes, as we brought up, getting into these complex repairs when in essence, sometimes just putting this bioinductive implant on top of that tear not only reconstituted the thickness of the tendon, and I always have difficulty understanding the biomechanics exactly, but would stress shield the area just enough to allow healing from the interarticular vantage point to recreate that cuff insertion. I mean, it is an incredible, you know, thing, and it's not one of these fly-by-night implants. There's data that shows that it works in augmenting double row massive repairs that we're fixing, in partial tear. So there is a biological component to this that cannot be denied. It works.
Awesome perspective on the conundrum. That was really cool, Jazz. Scott, what about you?
I actually started this whole journey with the bioinductive implant on the massive side because dermis wasn't working for me when I was trying to augment massive cuff tears, which is another topic altogether. But once I got comfortable with that, then I moved into the partials because of the whole how this thing would heal and reconstruct the footprint. I was an early adopter, so there was data, but I needed more.
When did you start? When was your adoption?
Probably 2015, 2014.
So very early.
Yeah. And so I started on the massive side and then worked my way to the partial side, and then we've worked our way into the middle based on other factors like comorbidities and so on. But it's been a situation where we've always known from large data registries that actual full thickness cuff repair has less stiffness than partial thickness without any augmentation of any kind. And so fixing partial thickness cuff tears with takedown and repair has always been a little sort of like not the most desirous thing. Partial pasta repair is even worse. So this has been a huge improvement in treating patients for all kinds of reasons.
Do you have a percentage of partial thickness rotator cuff tears that you're concerned that it is too much for the bioinductive implant?
Yeah, I mean, that number's a moving target like crazy because when we first started, way 10 years ago, it was, you know, more than 50% was scary, and then we went to 60, and then we went to 70, and now we've got surgeons in Europe are doing full thickness tears with follow-up MRIs and the like.
Oh, we'll talk about that.
Okay.
Yeah.
But my indications have expanded because of that problem.
Jazz, what about you? Do you have a preference?
I think, you know, certainly Scott's data, and I learned a lot from Scott as he was an early adopter. For me, his mild-mannered approach, and really when I heard him talk, I can see his struggle, and I was like, this guy's very honest, and he's presenting his, you know, dilemma that he has with these patients. And I listened to him closely over the years and how he was adopting and using it more. And that made me start to think, you know, maybe I should, you know, I'm having trouble with these patients. I don't want to see them anymore. And he's presenting this information that is dramatic. And I got to tell you, I mean, once I started adopting it, and it really was true. A lot of the things he was saying, and I got the benefit of his learning curve. I learned all his tricks and stuff that he presented at the courses.
Too. Thank you.
And I learned a lot, so I didn't fall into that. And then the idea of when do we stop? I think for me, the idea is when do I use some sort of fixation device into the bone laterally with the implant? A lot of these double row repairs that we're using, these massive tears that we're using to augment the repair, have sutures already there. So I'm just putting the implant to stimulate, get the milieu going, and biologically trying to enhance the healing. When I have this partial tear that Scott's talking about, when you're getting into that 80, 90% deal, but there are fibers there. And when you're intra-articular, it looks a lot better. That's when I'm starting to put the bioinductive implant down and then starting to put a staple laterally to place it into the bone.
So staple laterally for that specific pathology. Otherwise, just what's your staple configuration? That's the biggest question I always get: is how many staples do I use? When do I use the lateral staple, the bone staple? What's your thought behind the constructs?
Well, in terms of the lateral staple, it's when I need to get that fixation more laterally.
Yeah.
When I feel that in order to get healing or cover that footprint, I'll put a staple laterally.
Yeah.
Also, if it's a 90% thickness tear and I'm deciding not to take it down and I'm putting this implant on, I just feel I need something more into the bone. But in terms of the staple configuration, I've been using less and less and less because my test is when I pull the device off, the thing that holds the implant, if it doesn't move or is not moving that much, I'm very happy. And usually for me, that's about 4 staples.
Interesting. Okay. What about you, Scott?
I typically do 2 medial, 2 in the mid position, 1 tendon anchor posterior laterally if the infra is thick enough, and then probably one staple, bone staple anterolaterally because you run out of cuff tendon to hook to. But I really feel like the MRI drives where this implant goes based on the tendinosis, the disease of the tendon and location, and that will drive what staples go where. You know, because sometimes you get a situation where it's more medial than normal or what we would normally see, and that you end up using tendon staples only. So it's, or I guess they're tendon anchors.
Tendon anchors. What is your rehab protocol for these partial thickness rotator cuff tears with the bioinductive implant?
Sling for 10 days to 2 weeks, get them out.
That's it?
And get them moving. And, you know, from the Journal of Anecdotal Medicine, one of the first ones I did on a partial, or actually it was not a partial, it was a pretty retracted, massive tear on a gentleman whose daughter worked in our office. And he did a lot of metal work and couldn't have MRIs ever because he had metal in his eyes and stuff. So we did surgery on him and he did great for about 10 days. And then something bad happened. He did something that he shouldn't have. Felt a big pop. So we took him back to surgery and you've probably seen these videos at the meetings, but I've shown it. In 10 days to 2 weeks, the amount of seal that you get, this is my own opinion, again, from what I've seen personally, but the amount of seal and durability that bioinductive implant does on the native tendon is incredible. And so for me, I think I get them out quickly, let their symptoms drive how fast they want to go within reason, and get them into therapy right away.
Yeah, we did a cadaver lab early on together where we put the implant in and then we dissected it with just the water, and it was like sucked onto that cuff, with only 1 or 2 staples. So it's amazing when the fluid from the joint goes away from the arthroscopy with the seal that it has.
I actually worked on the delivery system quite a bit, just towards the tail end when things were getting wrapped up. And we would put one in, take it out, try different, put one in, take it out. And when we would go to actually pull them out, the amount of force that those tendon anchors had was surprisingly strong. That's the other reason why I feel very comfortable getting these patients moving, because once that implant has a chance to seal, get them moving, get them going.
Jazz, I've been in clinic with you and I've seen your patient population is young athletes, a lot of great New Yorkers who are trying to get back to sports. Does that change your protocol if you use the bioinductive implant or not? Does it expedite? Do you slow them down if they're trying to get back to sport?
So normally now I'm using the bioinductive implant almost on all cases for my repairs, just because of what Scott said. He brought up a point where I'm able to accelerate the rehab. So yes, for partials, sling for 10 days, get them moving.
Yep.
If you do a biceps tenodesis, does it change anything?
Yeah, so I don't send them to therapy. I just had a patient, called me up. We wanted to get him into therapy quickly. And when they go to therapy sometimes, yes, they know about the patch. And I did an arthroscopic biceps tenodesis and they were a little aggressive with him.
Yeah.
And he actually didn't pop it at therapy. When he was at a restaurant, he was grabbing a plate. Now you could say, okay, it could tear anytime, but I wonder if the excessive motion that they're doing in rehab may have affected the biceps. But getting back, so yes, I'm definitely accelerating, similar to Scott, getting my partials, but getting to therapy a little earlier.
I actually, when you have a tenodesis, I'll use like 3 Q-fix knotless and 3, boom, 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 and then just kind of let them go. Because let them.
How do you do it with 3? What's your technique? I use 1.
Yeah, well, on this patient that you want to get out and really get them moving and you don't trust them,
yeah,
I'll put
Q-fix knotless.
Yeah, I'll put 3 of them right in a row.
Yeah,
it's pretty strong.
Well, let's talk about. Can you explain your technique? Because Q-fix knotless just came out.
Yeah,
I think I use the standard Q-fix and do the crack out up and down and cinch it. But
I don't. I quit doing that years ago and just it's like a loop and pull and away you go.
Are you where are you putting sub-pec or
super pec? Super pec, arthroscopic. Yeah. So, but I think there's a role for certain. I don't do 3 routinely, but my routine is 2 anchors typically when you're doing a cuff and you're going to do traditional rehab. But on a bioinductive where you really have to do the biceps because for whatever reason you're going to do it, I overfix the biceps a little bit and get them into rehab fast.
Yeah, I mean, I think that's smart. See, I learned something.
Me
Chris,
too.
today.
Yeah, you're still teaching us.
I'm gonna put some more fixation because I think
sometimes you get a guy with a great big arm, like just a massive individual, someone who's like, I just had a police officer, his chest is like, he's just a big human. And I overfix the biceps and then it'll hold. And if you don't, it won't. You have to kind of dial in what you're doing to your host. Comes down to your host, comorbidities, tendon quality, all those things.
We just did a Markov simulation on the cost effectiveness is submitted to arthroscopy now, but we found that 100% of our simulations, if you look at quality life years and cost to payers and healthcare systems, that using it on every indication is actually cost effective.
Yeah.
So hopefully when that data comes out, if it does,
fantastic.
then it'll be something that'll be good.
That's very important.
Great.
The great thing about at least working in certain academic centers, they are cost conscious. They're, I believe, more patient conscious. Mm-hmm. And data like that really helps move the needle, to the right area where we can use this implant in more patients.
I've actually had conversations with nurse case managers in the work comp arena and said, we can do a traditional cuff repair on this partial, and this is the rehab protocol. So I lay it out, and then I said, or we can do the bioinductive, and this is the rehab protocol. And they're like, well, why aren't we doing this over this? And I'm like, well, you have to approve it.
Right.
And that's been helpful, like to explain not only the indications, but also the back end of the rehabilitation. And when done correctly, it really can move that patient along and get them back to work sooner, which is, again, important.
And it doesn't increase your time in the OR. I don't know how long it takes you, but I mean, even when I have a resident who's never done it before, they could usually do it in less than 10 minutes.
Yeah.
Which is unbelievable for the ease of use. All right, so let's change gears here now. So, Jazz, you bring up a really good point. So there was that Camacho study from 2024 that looked at intact cable, full thickness, small rotator cuff tears that were fixed either with double rows or with just the REGENETEN implant alone. What are your thoughts on the study?
From what I understand from that paper, there were smaller tears, right? When the cable's intact, it would indicate something between a small and medium-sized tear with different biomechanics. And at least our thought or understanding is that those are less likely to progress. So with that being said, the idea, and I saw a lecture by Rick Ryu from, Big Anna proponent. I don't know if he's still practicing, but
Rick is.
Yeah. So Rick talked about, can cuffs heal on their own? And he would present a couple of cases on some patients where there were smaller tears, and then he got follow-up MRIs, and there was some evidence of healing. I think a lot of them, when I looked at them, they were extensive partial tears, but it brought into question biology and what is going on in these specific patients. We've seen it in ACL tears, right? We've got some patients, they had a tear of their ACL, that classic proximal tear that we're now fixing on a lot of patients, but those would sometimes heal on their own. Freddie Fu would present these follow-up MRIs, and then you were like, yeah, I've seen that case before. I'm not the only one who's seeing that. But this is where I think it's fascinating, the results of this paper, because it shows you that we got to harness the biology. And the implant is doing something with the local biology there in these smaller tears where the biomechanics are more favorable, that putting the implant alone is somehow, just like Scott said, sealing that area. Maybe there's less synovial fluid that's percolating through that area that allows that seal that Scott brought up to occur with the implant. And maybe that's one of the reasons why the outcomes were better than when you sutured it, because when you sutured it, it's still porous. There's definitely, as good as we are, some fluid coming through.
Yeah, I think we don't know the upper limits of this implant yet, right? Like we don't know how far we can go. So there's going to be more to come with that, and it definitely we need to keep studying that because biology is critical, and over-tensioned repairs, we've kind of learned that's not great either. And so, the whole thought of doing a double row because you can, I'm not sure that's the right answer. I think you do it when you need it, but it's more about the delicate balance of the whole environment that you're trying to work in, which can be a pretty hostile environment with regards to rotator cuff.
Yeah, the interesting thing about that study was that they had the same PT protocol.
Yeah.
And if I remember, it was 2 weeks in a sling like we typically treat our regenetens. The question is, are we keeping our rotator cuffs too long in a sling? Because they had pretty good outcomes with the rotator cuff repairs. But for me, when I look at that study, it says maybe that patient that has 90% of their partial thickness cuff torn, where I typically take it down and repair it, maybe it actually does well with the REGENETEN implant because this study showed that they did it for full thickness and they had good outcomes.
It's not too tight.
Yeah, that's a great point.
I mean, you repair your favorite pair of jeans and the fabric around the repair starts to stretch and rip because it's too tight. The tendon's gone. So we're adding, not subtracting and tensioning.
Now, if you're going to use that technique, because I have not done it for a full thickness cuff, that's when we're probably going to put bone staples lateral, I would imagine.
Yes.
Has to be, right?
Because there's no tendon there.
Yeah.
100%.
Yeah, I do that for the most part, but you've already got a repair below, traditionally, whether it's double row or single row. What if the argument is that the implant is making the biology, exciting the biology there even more? There's actually data in these large tears where you put the implant on and it actually heals, with the goal that the repair that you did below is going to heal. This is just making it better and making the concept of changing the paradigm, right? That we always think, okay, the bone and the cells from the bone are coming up into the cuff and healing it. That's our traditional, how we recreate the footprint, et cetera. This is different. This is coming from the tendon, or in this case, the implant, stimulating something, I believe, on the tendon side that's allowing these things to heal better. It's a different perspective, but for me, the plan is to put a staple laterally, but if I'm concerned about my anchors and the crisscrossing that's going along with some of these double row repairs, then I may forego that.
Well, this was an absolute fantastic podcast. This was a joint venture Smith+Nephew podcast on partial
We're done
thickness.
already?
We could keep going.
Oh, man, I'm kidding.
Thank you, Dr. Jazrawi and Dr. Trenhaile, for joining us. It was a fantastic discussion on partial thickness rotator cuff tears. Thank you.